Good morning, everyone. I think we've heard some really interesting and stimulating presentations this morning. We've got about 15 minutes or so just for some questions. One thing that struck me is the massive challenge this means, because if you put what the Secretary of State said last week with what John has said this week, the NHS is engaged on an efficiency drive, the like of which it's never ever seen since it was formed in 1948. But at the same time, the message from the Secretary of State is that wrong site surgery or using the wrong prosthesis is simply not acceptable anymore. So you put that together, efficiency, safety, and as Glenn said, operational procedures. This is a massive, massive change, isn't it? I'm going to kick off and then I'm going to ask colleagues to come in. But the big question for me, aside from everything there, is actually capacity. This index is going to be published. There will be a target set for each acute trust, as I understand it, for the next financial year. It will be the same for industry. And I guess the question is, what are we doing to make sure and supporting the capacity to actually deliver this? John?
Thanks, Phil. Well, difficult for me to say, given that there's loads of conversations going on, as you can imagine. But there is an absolute recognition on a number of fronts. A, you do need the capacity to be able to put all this information together and make sense of it, and B, that trust clearly do need help and support. I mean, Lord Carter has visited about half the 22 personally, spoken to the chief execs, the finance directors and chairs, gone through the information, and they have found that really, really helpful. They've established things they didn't know, but they've also confirmed some things they did know, but didn't quite know how to deliver it. So it's a very, very good question, given that expectation has been raised significantly over the last couple of weeks. What is it the centre and the system can do to help and support trust going forward? I say difficult question for me to answer, but all I can say is I was with Lord David Pryor yesterday, and we were talking about this very issue. Lots of talk and discussion around the role of the regulators. Does that need to change? Does it need to be less regulation? Does it need to be more support? So you could definitely see maybe TDA and monitors roles changing over the coming months. Lots of talk around the existing support landscape. NHS IQ, for example, is the old kind of improvement body, has been focused really more on the commissioning space in recent months, because that was where the help was thought was needed. But actually, could they be another organisation that could be kind of played into the support network? So I can't really kind of answer your question other than we know there's a capacity problem, and we know we've got to figure out all the various organisations involved in supporting trust.
Okay, and we know GS1 has got to be a component part of the answer to that.
Yeah, absolutely.
Nishan, one single electronic catalogue, implication being huge reduction in the number of lines that are going to be bought by the NHS in the future. Big implications for some of your members. Some will find the NHS much more difficult to deal with in the future. Equally, perhaps there are some opportunities for longer term agreements with more investment in R&D. How do you feel it goes?
There are implications. I mean, one of the things that's striking here about, and we've been through processes where governments try to improve procurement, and we understand all of that. So you could argue on the one hand that electronic catalogues and a single catalogue already exist. There's a large central purchasing body in the form of NHS supply chain already. But there's some strong signals about where direction of travel is going. So moving from X number of lines to Y number of lines, downward shift, that's going to have implications. I think that in general, my members are looking at this and going, how do we balance the drive to cost contain, which is inherent in all of the signalling, with the potential of taking a longer term view on processes and systems that can also support uptake and adoption. And where we balance that, then there are clearly going to be opportunities for organisations, longer-term arrangements, a better sense, a different sense of partnership. And I think that's where the prize is.
And ABHI and your members are right behind the adoption of GS1. Is that right?
Correct. Yes. So what I was talking about before is, there are some challenges in terms of readiness, but from an ABHI perspective, we are helping our organisations move towards GS1 standards. Yes, there are other standards out there. The decision's been made about GS1. Fine. So, take that as it is and support people to try and move towards GS1 adoption.
Okay, let me take 3 or 4 contributions. Yes, sir. Well done.
Does this cube turn itself on? I was just going to provide a sort of answer to your...
Sorry, do you mind saying who you are,
sorry.
et cetera?
I'm Mike Sinclair. I'm the GS1 lead for Dorset County Hospital.
Thank you.
And I'm also on the Health User Group. I just got a sort of answer to your first question, Lord, is that actually trusts across the country are struggling to deliver cost improvement plans and programmes year on year on year. The unintelligent way to do that is by salami slicing, which means everyone's got to make 3%. And the best way for a hospital to do that is not to do that, is to do CIP intelligently across the whole of the organisation in a joined-up fashion. But to do that, it needs really strong and clear leadership in organisations. And if we don't focus on that, it'll just be a mess.
Okay, I think that's more a very helpful comment than a question. Where should we go to next? Yes, at the back. Well, that's going to be a challenge. We might have to do it in 2 phases.
Why not?
Oh, well done. Oh. Do you play for England?
I played netball many years ago, but I didn't catch that one. I've got a very simple question, and I know anything this short and simple is a bit of a caricature.
Can you just say who you are, though?
I'm sorry, I'm Anne Wrightson, and I work for a small company who sells to the NHS, and that's the root of my question. How are you going to stop this being the night of the long knives for small companies and local suppliers, bearing in mind that small companies are the strongest source of jobs in the UK, and we have a lot of a problem at the moment about employment. We've got a government promise about full employment, and there's aspects of this that may be going totally in the other direction. And the other aspect that I'm feeling worried that nobody said about this is all this is about reducing inventory, all that sort of thing. We know that just-in-time type supply chains can be very non-resilient when big and adverse things happen. How is the system keeping in the system the resilience for hospitals to be able to play their parts if big and nasty things happen?
Thanks. That's a great question. John, I don't want to put you on the spot, but we know that recently there have been complaints from SMEs about the way central government procurement has gone, where major contracts have gone to a very small number of companies who, it is alleged, and it's being investigated, I think, by the Cabinet Office, that SMEs were squeezed out. Is this a consideration in terms of this strategy for you?
Of course it is, Philip. As someone who's been on the end of SMEs complaining to me for about 15 years, it's something kind of ingrained in me to think about this issue. First of all, let me be straight. I think it is inevitable that with a single NHS catalogue, and we have been looking around the world at global best practice, and we are seeing that in various hospital systems around the world, if you take sort of the basic consumables to run a hospital, the number of lines tends to be in the order of 6,000 to 9,000 lines. We know that there tends to be over 90% compliance to that list by the hospital chains, and whenever a supplier or a product is changed on that list, 80% compliance is achieved within a month. Now, notwithstanding the question, that's what we want. That's exactly what we want. We need to build systems on both supply side and the NHS side to get to that. Now, that does inevitably mean there's a risk to SMEs. Conversely, it could be an opportunity, of course. I mean, there's a capacity issue, because if you're a winner, then it's an advantage. But my view on the SME issue is that if it's kind of basic consumables, we have to make sure that there is there is a position or a place for SMEs to be able to pitch what they've got. If it is truly different, it's truly innovative, and it truly can reduce cost in NHS, we have to create something that allows that to happen. Without that, then you're absolutely right, there's a real danger that SMEs could get locked out. But there lies the issue. SMEs need to prove they are adding value and they are able to contribute to the efficiency agenda in a way that maybe, other suppliers are unable to. And to me, that's the trick with this. If it's just an SME who, frankly, is just importing stuff from, I don't know, the Far East, then I'm not so sure. So it may well be that will be addressed. So I absolutely strongly believe there's a role for SMEs, and we should be actively supporting and looking for SMEs, provided they are able to make a difference.
Can I just push you on that? Let's relate that to innovation and the work of the AHSNs and the innovative project. You clearly, that has to continue alongside what is clearly a much more directional, centralising approach, doesn't it? Yeah. Nishan, I mean, ABHI, you've got some huge global players and you've got SMEs in membership. So you deal with this constantly.
Absolutely, Philip. And the majority of our members, so Madam, your question resonates with me. The majority of our members are SMEs, and we're fortunate in our board. We've got about 3 or 4 British MDs of British SMEs. That question talks specifically to my point about balance, because it is difficult for SMEs to engage, do business with the NHS where it's fragmented, the decision-making system seems arbitrary, and that is why it is important that we have improved, consistent, coherent systems where we can eradicate some of that fragmentation, make the innovation adoption process that much more consistent and coherent. That gives SMEs who don't necessarily have the same scale and resources as larger multinationals the ability to compete on a level basis.
Yes, sir. 2 gentlemen there. Shall we try and take you both together?
I'll to him, shall I?
Darren Stanley from Sysmex UK. First a comment and then a question. The comment is, you're talking about taking fully 98% of the products out of the catalogue. And I think you have to consider the risk of actually winning the role in the catalogue and having your product in there as an SME, and their ability to ramp up production to cope with that. That could equally be as big a risk as actually losing the business in the first place. The question is related to where you see the tender process fitting into this. If a load of products are supplied under the tender procurement process and they're on the catalogue, how do you see those aligning?
Okay, capacity to deliver tender process. The first one was the issue of an SME that won a major contract, and then actually the real problem for them was actually deliverability.
So to address those 2 points, on the first point, don't assume that a single NHS catalogue means it's this supplier with this product and this price and that's it. It has to be connected to strong category strategies that are fully aware of market issues, maintaining competitive markets. So, and it could be in some areas where pricing is sensitive. You could have sort of dynamic purchasing systems. You could be constantly changing that catalogue quite frequently. But the point is, it's a single point for trust to go for their goods. So don't get hung up with this. It might be an award to a supplier for one product for that price. It won't be like that. On the second issue, which is related to that, is who makes the decisions and what's the process for getting stuff on the catalogue. Now, you're quite right, we do currently have one vehicle for doing that, which is DHL. We're currently in the process of renegotiating that contract, either to extend it or to look for alternatives. But of course, in doing that, we need to make sure that it's what the NHS wants. And one thing I will say about those negotiations, and that is the decisions about what goes in that catalogue and the ownership of that catalogue, we want to come back into the NHS. And that's quite a shift in our views. And if the catalogue comes back into the NHS makes the decision then about who undertakes the activities around procurement. Now, I think this will also fundamentally affect the procurement landscape. We've got to consider the consequences of that, so I'm not going to openly say what we're going to do yet, but it does mean, we don't believe that competition between procurement organisations is going to work with a single NHS catalogue. So I will say that I do believe a national catalogue will fundamentally change the procurement landscape for the better, I believe. So suppliers are not confused about who's representing who and so forth. I'm not going to say what it will look like yet, because we're still working on it, but I do think it will address a lot of the issues, certainly the industry have said to me over the last couple of years.
And of course, that works for SMEs as much as for big
It
companies.
absolutely does, yeah. Single point to go, absolutely. Mm-hmm, yeah.
Nishan, anything to add to that?
I mean, I talked about the notion of behaviour in my presentation, Philip, and this is a real example of how behaviour is going to impact on making some of these decisions that the gentleman's kind of noted. Clear risk. That process that John's talking about to get to the catalogue, one of the things I would absolutely want to stress is that we don't do it on a Pareto basis. It's just an arbitrary notion of here's the Pareto and there we go, there's the X number of products for the catalogue. It has to be rigorous, exactly like this bottom-up process that we talked about. It's got to be fair and objective.
Okay. There was a gentleman just behind you, last one I'm afraid.
Jason Webb, Kent Pharmaceuticals. I'm fortunate enough to have a pharmaceutical portfolio and a medical device portfolio that I'm responsible for. So I can really see the differences between pharmaceutical procurement and medical device procurement. And I would say that pharmacy have their ducks in line. Medical device procurement, I don't think the ducks are even in the water yet. One of our devices, though, was responsible off the back of an EU directive that was a Safer Sharps directive. And we invested a lot of money to develop a product that still today is being ignored within the NHS because trusts do not understand what they need to do because there's no central lead at procurement to drive the directive forward. If that directive was implemented today, our product could deliver the NHS multi-million pounds worth of savings. We're about to enter into a new EU directive of the Falsified Medicines Directive, which is going to be a massive change for industry, pharmacy, wholesalers and all stakeholders. I've sat on several groups for the last 8-9 years talking about shortages. We still can't get shortages right within the NHS. I'm not sure how we're going to implement a fundamental change in the Falsified Medicines Directive within pharmacy within 3 years. How does the panel see that changing?
Thank you. Very interesting question.
Can I just address your first point there around standards? I didn't say this in my presentation earlier, but the logical conclusion, if you're going to look at a national catalogue, is that it takes you to national standards. And I know Lord Carter is particularly keen that we get to, particularly in medical devices where there's lots of hearsay about differences between particular devices. He wants to get to national specifications, almost like generic specifications for medical devices, taking into account the very things that you've raised. And he would like those to be agreed nationally with NHS England, so it gets firmly embedded into standards from NHS England into commissioning. How we do that, I think, is a huge challenge, but that is definitely the direction of travel he wants to take. And I'm sure there's lots of issues, and I'm grateful to hear any kind of views on that as a prospect. But I do think that's probably the right way forward into addressing many of the issues you just described.
What about the directive? ABHI have been working on this, haven't they?
We worked with our members on the safer needles one, for instance, but not necessarily the falsified medicines aspects. That is a sector of sector of the industrial base that's not within our membership.
Okay.
But in terms of, if I take some of the learnings of the work that we did through our Safer Needles Network approach, for instance, where you've got good engagement with clinicians and you've got alignment with where industry goes, then you could find a way to get to a position where much more national specification of areas can be helpful.
And can I just add to what I just said, because there was a comment made by Secretary of State about putting the right hips into patients, and I do kind of worry about the way he said that, because It's not quite how we worded it for him. What he was saying is that what we have found is in orthopedics, for example, in hip surgery, there is a variation between trusts in their use of fixation technology. In other words, whether they use cemented technology, which is older, well-proven, 20, 30 years evidence, versus uncemented technology, which has less evidence and is more costly. And what we're seeing is that some trusts, use cemented technology wisely, and typically good, when you look at it in terms of outcomes, because you can then compare it to outcomes, 70-80% of hip surgery is using cemented technology. Then we find other trusts that are 90% uncemented technology. And you ask yourself why? Why has that happened? And that's what he meant by this. And the evidence is there, so it's not just about a choice of a particular product, it's actual clinical evidence that's driving some of the issues about what is used.
And of course,
so this is where standards come in.
In your remarks, you talked about equipment used by doctors coming a little bit further down the line. And of course, behind that is the whole question of individual doctors and their wish to make individual decisions, which of course comes right up against that practice. It does. I have to say, I think if you take on the orthopedic surgeons first, then that would be a very good signal to the rest of the service.
I'm not taking them on, Philip. Professor Tim Briggs, who's the current president of he's taking them on.
Right, look, we're going to break for 20 minutes coffee. Can I thank John and Nishan for a fantastic first session? Thank you.